these are tools with huge potential, but how you use a tool is what it's all about. The context for it and what you seek to achieve by implementing these tools, I think, is going to determine whether these are democratizing or dystopian.
My name is Graham Howarth, and it gives me great pleasure to welcome you to this brief trailer or spoiler where I'll be speaking to Dr Kantor, who's our speaker, or one of our speakers, at our 16th Ethics for All, which is going to be held on the evening of Thursday, the 19th of October at 7 in the evening. So I'll be speaking to Gary, finding a little bit about him, a little bit about AI, and a little bit about his talk. So Gary, welcome, and thank you very much for joining me today.
Thanks, Graham. It's a pleasure. Looking forward to our chat.
Now, my understanding is that you are South African educated at the undergraduate level anyway. Maybe you could just give us a little bit of background about, your course to date through medicine.
Sure. It's a bit of a long journey, crossing the Atlantic a couple of times, but I'm a UCT graduate. And like a lot of my sort of contemporaries, I did eventually, not long after qualifying and working a little in Zimbabwe, where I was born and grew up, I headed over to North America and I actually spent 16 years over there, including 6 years in Canada, part of that in Western Canada, doing sort of a rural general practice, which is pretty interesting. I ended up doing a residency in anesthesia in Toronto, and then migrating south across the border to what I thought were better opportunities in the United States. I spent 10 years in Cleveland, including the Cleveland Clinic, and in a big academic medical center over there before coming home to South Africa, which was initially meant to be a 1-year sabbatical, time off for good behavior. But then we sort of, liked being back home in Cape Town, particularly, and all that it has to offer, and sort of the challenges of a different kind of medicine in many ways. See some things the same. And I brought some, ideas and experience back with me that I thought I could transplant into the local environment. So I was primarily a clinician, as I said, in general practice and then training and then 10 years in a big medical center. But along the way, I got interested in a couple of things that maybe, of relevance to the presentation that we're going to do next month, particularly around quality and systems and the role that they play in the outcomes that we want to have for our patients. And having a fairly strong nerdy streak in me, I got sort of very interested in information technology, and we're talking, a couple of decades back in the early days of the internet and all of the sort of e-health, m-health, all of these labels that got attached to things that I think we think of, these days as inherent to everything in life and to medical care a lot. And then we're going to talk about artificial intelligence, which is the latest generation on that. So I'm giving you, my story in brief and the intersection with some of the interests that I think are really exciting and interesting and going to shape the way we practice medicine in the coming years.
So would you see yourself as an anaesthetist if I was to say to you what specialty? I mean, when did you last give an anesthetic in anger?
So actually, I was at Somerset Hospital this morning, public hospital that's pretty close to where I live. I was in theatre this morning. So this is I'm trying to keep myself honest. And I think, one of the risks of people who get into IT and technology things in general is that they kind of lose touch with the reality of medical practice. So I did take a bit of a break from clinical practice, but I'm back in it. And it's really exciting to actually hang out in a teaching setting with younger people and learn from them and learn with them and sort of contribute some things that I've learned over the years about practice. But actually, I'm learning a lot every day that I hang out in theatre with registrars. And you asked me, am I an anaesthetist? So there's a little bit of jargon or language involved in that question. I think you're being provocative, as you promised you would be. So in the United States and Canada, an anaesthetist actually is a nurse anesthetist, as they would say. In South Africa, doctors are anaesthetists, although increasingly we're calling ourselves anesthesiologists, which is hard for many people to pronounce. But here we are. It's the same work. But actually, it's a broader question about how one does anesthesia. Is it in a team? Is it individual? Are you part of a system? What's that system look like? How do you get the best outcomes? So, that small question of whether I'm an anaesthetist or something else actually opens up a whole conversation all on its own.
Well, I think that is also brought home with SASA. I think they like to call themselves the South African Society of Anaesthesiologists, and I did make the mistake once of referring to them as anaesthetists. Just moving on to the concept of artificial intelligence, and I will provoke you by saying I believe you're a bit of an expert in the field.
So it's funny you should say that, because this morning in theatre, one of my very experienced colleague consultants was asked whether he was an expert, and he said, "No, I'm a specialist." And then we talked about whether that's the same thing, being a specialist and being an expert. But to take it away from that thread of conversation, I think AI is sufficiently new that, I'm not sure that there are many people in the world who are experts. There are some. There have been some people doing it for a long time. I actually, before I went to medical school at UCT, believe it or not, I spent 3 months in a computer science program in London, the University of London, University College London. So I did have, as I said, this sort of nerdy technology-oriented streak, which a lot of anesthesiologists have. So I was in on the very beginnings, late 70s, and I learned to program in a programming language called PL1, which stands for Programming Language 1. So that gives you an idea of how far back this goes. And one of my friends from that BSc program in computer science, was interested in artificial intelligence all the way back then and started a career in it. And that career, I have to say, he might agree or he might disagree, was relatively unsuccessful, because these ideas around AI have been a little bit of science fiction, and then they seemed like there was a possibility they'd come true, and people worked on it for decades and decades. And what's happened just in the last few months, actually, is a form of AI that we'll talk about in the presentation, that seems to unlock a whole lot of the potential that people only imagined or thought was possible 20, 30 years ago. So there are some people who've been along on that journey for decades, and I think you'd call them experts. But I think most people are just beginning to grapple with the potential for this new kind of AI. And then if you ask someone, are you an expert in AI, you'd have to say, well, applied to what field? So we're obviously we're interested in, I think we should be interested in its implications broadly for society, as doctors and as custodians of a healthcare system. But AI in healthcare brings its own sets of unique questions and complexities, because we're working in very complex systems, and we know that when you try to put technology into a complex system, it very often doesn't take shape the way you wanted it to, or give you the outcomes that you intended, or even at the cost that you hoped it would come in at. So we'll talk a bit about some of that, because I think those are really important systemic questions. And although I'm not an expert in AI, I do know something about healthcare systems, having been working in them one kind of or another, public, private, South Africa, North America. So I've seen some variety, and I've seen some commonalities, and hopefully we can all learn together about how to do this well.
So this is a bit of a trailer for your talk itself, and I take it in the background that you're sort of making a distinction between task-based and possibly the new sort of growth area of generative AI, and I'll just leave it there because I'm sure it'll be touched on in the talk and how these may play a role in the future. Now, just moving on briefly really to the ethical issues, because after all, this is ethics for all. I suppose one of the questions is, you know, as with other technologies that have been introduced and that are expensive, is this an exciting development that can help us, you know, help the disadvantaged and, you know, improve care in South Africa? Or is it merely going to exacerbate the distinction between the haves and the have-nots? I'd be interested in your thoughts on that.
Well, that is the big question. So can I give you a simple answer to that? I think it depends. It depends on leadership, and you know, these are tools. These are tools with huge potential, but how you use a tool is what it's all about. You know, the context for it and what you seek to achieve by implementing these tools, I think, is going to determine whether these are democratizing or dystopian. But to give it a positive note, I think there's huge potential to level things up, because in Africa, Southern Africa, in all of our contexts, there are huge disparities, obviously, between public and private sectors in South Africa and across the continent. But I think even on both sides of this, there's an opportunity to improve care. I think one of our main issues is shortages of skilled personnel, and AI inherently brings new capabilities to all kinds of specialists and generalists. So we'll talk a bit about radiology, where a lot of this is happening, and ophthalmology, which is actually a lot about imaging as well, and the potential for you know, better care to fill the sort of skills gap and knowledge gap with AI. And we'll talk a bit about cancer screening and the potential there. And then, you know, whether the technology is ready to support diagnosis and really full-blown clinical applications. We'll talk about that. So there's a trajectory of, obviously, to where these things get better and better. And so for generative AI, which you mentioned, as opposed to task-based AI, I think we're going to talk about whether it's ready, when it's going to be ready. But the positive spin on all of this is, I think, huge potential to improve care in under-resourced environments, but, you know, misused. And we'll give you a couple examples of that. Maybe, you know, if one uses this to further burden clinicians who already have lots and lots of sort of administrative tasks and not value-adding work that's not clinical, that's not interacting with patients directly. If we add a lot of that in the form of AI to already busy clinicians, then we're not going to do so well. And that could be quite dystopian.
Right. Well, thank you very much for that. I mean, personally, I think, I know we refer to them as our cell phones, but I'm more and more starting to think of my little cell phone as my exobrain. And I think if we can get AI working through that exobrain, then we can spread the word quite broadly. Now, I'm going to leave you with that, Gary, because I think we've come to the end of our chat. I'm very grateful to you for the opportunity to chat to you about it. Hopefully, we're going to entice people to come and listen to your talk itself. I know, unfortunately, you won't be there. It'll be a pre-recorded talk, but I'm really looking forward to it. On that note, I really would like to invite all of you listening to this trailer, or teaser, if you will, to attend our Ethics for All event. It is the 16th one. It's on Thursday, the 19th of October at 7 in the evening, and I look forward to hosting the event and hopefully seeing you there. I'm Graham Howarth. I've been your host, and thanks very much for listening.